So let's wait a little bit. Everybody just press the play. All right, we can start. Hi, everyone. Hi, Dr. Daniela Rios. How are you?
Fine.
Good. So hi, everyone. First of all, thank you so much to be here and enjoying with us all the lectures in this big event of the IAPD. I'm Carla. I'm from Brazil. It's a pleasure for me to be here talking with you and also introduce you important professor that we have here in Brazil, Dr. Daniela Rios. So thank you so much, Professor. Thank you so much to be here. And I'm going to introduce her for you all about a little bit of the big resume that she has and what she has been doing here in Brazil with the research and everything. And then she's going to have around 50 minutes with you all to do the lecture, and then after the lecture, I'm gonna be back. So Dr. Daniela Rios, for you, Dr. Rios, she has the education and qualification in dentistry in 2008, postdoctor in cardiology from the Bauru School Dentistry is the University of São Paulo here in Brazil in 2004. She has the PhD in Pediatric Dentistry also in the Bauru, São Paulo University, and her Master of Science was here in Brazil in São Paulo, in Bauru. Since 2008, she is a professor of Pediatric Dentistry in São Paulo, Bauru School of Dentistry. Since 2011, she is associate professor in Pediatric Dentistry in University of São Paulo. Her focus is in scientific and clinical activities research, focus in cardiology, in pediatric dentistry, preventive and operative dentistry, developing dental defects, and erosive tooth wear clinical focus also in pediatric dentistry. So Dr. Daniela Rios has published more than 160 scholarly articles in professional peer-reviewed journal with international circulation and with 1,576 citations, and wrote 12 chapters in books. So she's associate of Journal of Applied Oral Science since 2018. Her lecture right now is the lecture 12, and the title is Understanding Bioactivity and S-PRG Technology for Helping Solve Daily Pediatric Dentistry Concern. So I would like to thank you, Shofu, that is the sponsor of the lecture, this lecture. And about this title, everybody knows that nowadays we have two main challenges to deal in pediatric dentistry. Two challenges is dental caries and development dental defects. So mainly hypomineralization. Consider that this alteration brings many consequences of the child, family, and society. Their management is necessary. On this scenario, the bioactivity materials are important tools that can help us, professional, clinical people. So, however, the understanding of their mechanism of action, indication, and how to operate these products are fundamental for promoting oral health. So, thank you, Dr. Daniela Rios, and thank you, Shofu, again. So, you are welcome, and go ahead. Let's go.
Thank you, Dr. Carla Pereira.
One more detail, excuse me, Dr. Daniela. One more detail, everyone. Okay. In the end of the presentation, so Daniela, she's going to be here for you all about 50 minutes. And in the end of the presentation, I'm going to read some questions. So you can go ahead, put your questions in the Q&A box. So just write there your question. And after the presentation, I'm going to read for the professor so she can answer you. Also, if you don't want to just write your question, you can see the question that everybody is writing and just press like. As soon as you press like, I'm going to read the question that is most likely. So it's easy, it's probably everybody doubts. So in the end of the presentation, I'm going to be back. So thank you, Daniela. Now it's your time.
Okay. Okay, thank you, Dr. Carla Pereira, for these very kind words, and good afternoon, maybe good morning or good evening, we don't know. So it's a pleasure to participate in this outstanding virtual meeting organized by IAPD. Yesterday, I have a chance to see some of the lectures, and the quality of the lectures was wonderful, and I really enjoyed to see them. So congratulations for the organizing committee. First, I would like to thank the organizing and the scientific committee for the invitation, and a special thank for our president, Marcelo Bonecker, for giving me this great opportunity. I am very happy to be here because I am here in my house, in my home with my family, and I hope they don't make noise today. And I am with people of all parts of the world. And as a Brazilian, I like to give hugs. So just feel a warm hug on all of you. Before I start my lecture, I take the opportunity to invite you to visit the University of São Paulo, which is in the state of São Paulo. The University of São Paulo has 3 dental schools in different cities of São Paulo, and I am from Bauru Dental School. Just let me take my pointer here, okay? So we are open to share experience and make partnerships if some of you are interested. I also want to thank Shofu, who sponsored this lecture. I declare that I have been invited to make a training in Shofu company, but I have no financial interest that would create a conflict or restrict my independent judgment with regard to the content of this presentation. Today, I'm going to explain what is bioactivity and S-PRG technology and how they can help us solving daily pediatric dentistry concerns. First, we have to establish our main problems in pediatric dentistry. I don't know if you agree with me, but I think that dental caries and also dental developmental defects, especially hypomineralization, are the main challenges in nowadays. On all my lecture, you will have to keep in mind that bioactivity and also S-PRG fillers can help us solving these problems, but it's essential to consider 3 main points before deciding the treatment. First, we have to look for the scientific evidence to guide our dental practice, and the highest level of evidence are clinical trials and systematic reviews. But sometimes we have to be satisfied with the best evidence available. But this is not enough. We have also to consider professional expertise. And today I'm going to share with you some of my expertise. And finally, and not less important, we have to consider the patient or family preferences and needs. Taking this aspect into account, I have a question. Do the child need only restorative treatment? What do you think about this question? Yesterday, Dr. Juan, he usually to give 3 seconds to the audience to think about the question and give the answer. On these opportunities, I could not answer, but what is the answer now? Do the child need only restorative treatment? In my opinion, of course not. So we need to be able to see the child behind the tooth with an holistic vision and guarantee their well-being. And this is my most important aim as a professional, and this is what guides my research and my practice. and it's also gonna guide this lecture. Before we talk about S-PRG, we have to understand the concept that was considered to develop this technology. Therefore, we have to know the definition of bioactivity. The concept comes from medicine, and for the Academy of Dental Materials, the definition of bioactivity is the ability of a material to leach ions with a potential role in biomineralization. However, I like a more generic definition that considers bioactivity as the ability to mimic an action or an effect of the organism. The most known materials with these characteristics are glass ionomer cement and calcium silicates. So let's have a look at the glass ionomer cement. I know that dentists usually, and also researchers, clinicians, usually do not like very much about chemistry, but the chemistry can help us understanding the material and also have an impact on how we use this material. So I'm gonna share with you some chemistry, but I think you gonna like and understand. Here we have a liquid constituted of water and carboxylic radicals and hydrogen ions, and the powder has glass particles with calcium, aluminium, and fluoride. When the powder is mixed with the liquid, it initiates a series of acid-base chemical reactions. First, the hydrogen ions will be released and will attack the glass filler, and this glass will release aluminium, calcium, fluoride only from the surface layer of the glass. The reactions take place between carboxylic radicals and calcium and aluminium, and this is what we call the polysal gel, which is the matrix of the glass ionomer cement. And this matrix is also responsible for some poor mechanical properties of the material. However, on the other hand, this framework is porous, and ions with small dimension are free to move through the material. So after mixing, glass ionomer has more fluoride than the oral environment, and fluoride will be released. Over time, the amount of fluoride obviously will diminish, and when the individual's toothbrush with fluoride dentifrice, when there is ingestion of fluoride water, professional fluoride application, the amount of fluoride in the oral environment will increase, and fluoride will move into the glass ionomer cement, recharging the fluoride. So let's take a look on how glass ionomer cement can help us solving our main clinical concerns. And I will start with dental caries. Is there any advantage in restoring a tooth with glass ionomer cement? Here I have a restoration of glass ionomer. Let's have a look on the scientific evidence. So the question is, do the leached ions have an effect against dental caries lesion development? We have a systematic review showing that secondary caries rate of the occlusal restoration was not different among materials. Oh, this means that the glass ionomer does not have bioactivity? Just a moment. Because this systematic review also showed that occlusal proximal restorations with glass ionomer cement was associated with better ability to prevent caries lesion. So there is evidence showing that this material has this effect. It is bioactivity. Another important question that we have that rises is, do every type and brand of glass ionomer behave similarly? I will give you 3 seconds to think about, and I will answer. Unfortunately, not. When I think about the type of the ionomer, the evidence shows that best survival rate of the restorations are achieved with resin modified and high viscosity glass ionomer. But an important point is that the brand also impacts on the glass ionomer cement performance. And here we have some evidence, and it is always important to analyze cost effectiveness when choosing the glass ionomer cement. We have to view the type of ionomer, the brand, and analyze the cost effectiveness when trying to choose the glass ionomer cement, the best one for what you want. Okay. Now, the other concern is molar incisor hypomineralization. Here, the D3 group site shows that 1 in 6 school children presents hypomineralized teeth. So, the probability of facing this problem in the clinic is very high. Yesterday, on Sunday, we had the wonderful lecture of Dr. Elfrink, and she defined that molar incisor hypomineralization is a qualitative developmental enamel defect, and when the quality of enamel is high compromised, it gets lost and the restorative treatment will be needed. However, strong recommendations are not possible for managing molar incisor hypomineralization based on what we have now in the literature. But I will share with you some of our experience when using high viscosity glass ionomer, and that was a very good experience. Here we can see an atypical caries lesion as a consequence of the hypomineralization, because this tissue was lost, and due to the absence of toothbrushing due to pain, the development of the caries lesion. This patient was indicated for endodontic treatment due to the extent of the lesion, but our treatment was not this. The treatment consisted of selective caries removal with manual instruments. Here we took all the infected dentin, and then we restored with a high viscosity glass ionomer. The brand was Equiafort, a very good glass ionomer. Here we can see the final aspect of the restoration. We have 3 years follow-up of this patient, and we did not need to do any repair or replace this restoration. And this result is in according to the literature. As I said, we do not have high evidence, but we have clinical trials showing the good performance of the glass ionomer cement restoration as a conservative approach for young permanent molars. Here we can see after 2 years, the survival rate was around 87%. And we have also more evidence with clinical trials with 1 year follow-up showing a survival rate of 78% and 98%. And this good performance might be due to the type of adhesion between glass ionomer and the hypomineralized enamel. Here, the carboxylic radicals will react with the exposed calcium of the tooth, resulting on a chemical adhesion. And I suppose, there is no evidence yet, I suppose that this type of bonding is less affected by hypomineralization when compared to micromechanical adhesion of the composites. However, in some cases, even after restoration, the patient is still complaining about pain because some opacities are not covered by the material. And for these cases, we developed a simplified occlusal replica adapted technique with glass ionomer cement. This clinical case was published on JADA. Here, an already restored tooth, but even after restoration, the patient still showed symptoms of severe hypersensitivity in the permanent molar when eating hot or cold meals and when brushing her teeth. First, maxillary and mandibular impressions were obtained with alginate. In the lab phase, the wax-up of the missing structure standing to the areas with demarcated opacity was performed. Then an additional silicone impression of the wax-up was obtained to be used as a matrix for restoration and to accurately reproduce the occlusal and proximal anatomy of the tooth. In the clinical phase, after administration of local anesthetic, the tooth was isolated with cotton rolls to guarantee a working field without saliva contamination. Next, the old restoration was partially removed and polyacrylic acid was applied on all tooth surface for 10 seconds, followed by rinsing and drying with a contour roll until the surface was slightly moist. The silicone impression was filled with conventional glass ionomer cement. Again, we used Equiafort. And positioned it on the tooth and pressed it for the setting time of the glass ionomer around 2.5 minutes. Afterwards, the restoration surface that was protected with coating agent against water gain and loss. And the finishing and polishing of the restoration with rotating instruments were carried out only after 24 hours to avoid a negative impact on the material performance. And we was very happy because after a week of the restorative procedure, the patient reported no more hypersensitivity. And we got more happy because even after 1.5 years, she had no further tooth structure loss, the restoration did not fail, or symptoms of sensitivity was not present. So, for all these reasons, I am a glass ionomer cement lover, but this does not make me blind regarding the limitations of the material, especially regarding some mechanical properties such as material wear. As we can see here, there is wear here, and also regarding aesthetics. These are the limitations. So, considering these limitations, researchers and the industry are looking forward trying to develop a material able to present the bioactivity of glass ionomer cement and also the aesthetics of the composites. And there are several new bioactive materials, and this is a very good review for the ones who want to know a little bit more of them. But today I'm going to talk about S-PRG technology. Okay, now I'm going to cast a spell so that you don't get confused. So you will know that everything I say from now is not glass ionomer cement, okay? The first important information is regarding the development of an exclusive glass containing fluoroborosilicate baixo Fu, which is a very reactive glass. This glass is not used on their glass ionomer because they are so reactive that there is no time to handle them after mixing with polyacrylic acid. But this is the most functional glass that is used for the development of the surface of the S-PRG filler. Let's understand what is S-PRG filler. It means surface pre-reacted glass ionomer filler. Therefore, the surface pre-reacted glass ionomer corresponds to the final process in which this multifunctional glass is treated to achieve an adequate size. Then another layer is applied over the glass to protect the glass, named modified layer. This modified layer is porous, and when sprayed with polyacrylic acid solution, the hydrogen ions will attack the multifunctional glass, releasing 6 ions and starting an acid-base reaction that results in a matrix. In addition, the sodium will attract the ions, forming a complex with these ions. So, this is the glass ionomer layer. Let's see all the filler to understand better. Here we have the glass ionomer layer with around 50 nanometers. The surface modified layer has around 200 nanometers, and in association with the glass core, all the particle has around 3 micrometers. So the filler is 60 times bigger than the glass ionomer layer. This layer is very, very thin. And this is the reason why there is no compromise regarding the mechanical properties of the materials when using this filler. When this filler is in the oral environment, when there is contact with water or acid in the oral environment, water will attract the sodium, and sodium will release all other ions. And each ion will have a role in the bioactivity of the filler. Let's see. First, boron has an antibacterial action, mainly for preventing bacterial adhesion. Aluminium have a sensitivity control. Silicate contributes to remineralization, and fluoride, as we know, decreases the demineralization and enhance remineralization. Strontium is able to neutralize acids, also a characteristic of boron, contributing to acid resistance and the effect on remineralization. And as you already saw in the mechanism of the S-PRG filler, sodium contributes to the activation and optimization of the other 5 main ions. I introduce you Dr. Nakatsuka, affectionately known as Mr. Giomer. He was the one that developed this technology with his team, and I learned all these mechanisms with him in a training at Shofu company. But sometimes I could not understand, I could not see the chemistry behind, or I couldn't even understand the differences between or among the materials. So some of you, like me previously, is saying, oh my God, I did not understand. What is the difference among Giomer, among S-PRG filler, glass ionomer cement? So my magic did not work, but I'm going to explain you that all products that have S-PRG fillers are called Giomer. So S-PRG is not the final product, is only the filler that will compose the material, okay? And this material is called Giomer, and Giomer is not a type of glass ionomer cement. It's another thing. The bioactivity of glass ionomer only inspired the creation of the S-PRG filler, okay? But if you have any doubt, please let me know at the end of the lecture. So the S-PRG filler is used in the composition of many products, composites, and we have the conventional ones, we have the low shrinkage, book flowable. We also have injectable composites with a special device that really help us. I will explain later. And also adhesives and some preventive materials. And the scientific evidence regarding S-PRG technology is being built. Although many studies, 190 in the literature, there are few randomized clinical trials. And the results varies according to the method, to the type of the product, and the concentration of S-PRG filler. Just to you better understand the S-PRG, S-PRG filler will be part of the composition of the resin. And it can be in different size according to the needed characteristic of the product, and also with addition of silica, because the use exclusively only of the S-PRG would be very expensive. So there is S-PRG filler and also silica. Let's have a look on the characteristics of the composites. There are many in vitro studies showing that the mechanical properties of the composites with Giomer technology are similar to traditional composites. In addition, they have been reported to inhibit Streptococcus mutans growth and metabolism on their surface, and these effects are attributed to the release of boron, fluoride, aluminium, and silicate, mainly boron and fluoride. However, current concepts of cariology shows the importance of acting on the de- and remineralization process, and in this scene, fluoride, boron, and strontium play an important role on the remineralization. Here we have some evidence. On the other hand, silicate and sodium are important ions for the dentin remineralization. Here, this study used a dentin protein model to induce mineral formation after incubation in a solution with and without S-PRG. And the S-PRG fillers significantly reduced mineral induction time. It was faster. And they could observe larger apatite crystals with the S-PRG fillers when compared with the control. However, the need of dentin remineralization stimulation is controversial because there is evidence showing that pulp-dentin complex is able to remineralize without stimulation. Even with walks between the mineralized dentin and the restorative material, there is remineralization. And we have to study is what is the impact of faster remineralization or a better remineralization in the survival rate of the restoration. We have to answer this question in the future studies. Another important property of the S-PRG fillers is the buffer capacity, which maintain the neutral environment near the restoration against cariogenic pH fall or against erosive acid fall. And the main responsible for this is borate, which is a pH buffer system. Now that we know how it's the mechanism and how which is the function of each ions, what is the evidence? What evidence we have regarding Giomer? There is one randomized clinical trial showing a very good clinical performance of this material, but it's also necessary to have results regarding its effect on the prevention of caries lesion development around the restoration. So in the future, we will have also to answer this question and show the evidence. I have some experience with this material, and I'm going to share with you how I have been using them, especially for caries lesion and hypomineralization. These composite resins are very easy to handle, facilitating the restorative procedures in pediatric dentistry. So let's understand a little bit how they work. Here, a paste was placed in a conical shape on a glass plate. While the plate was held vertically, the length of the flow paste was measured in 1 minute. Here, flow 0, 0 means that the paste did not flow 0,4. Although injectable, it is not flowable. Flow 0,3 means the length of the flow is 3 millimeters, and flow 10 means that the length is higher with 10 millimeters. So we have been using this resin to seal non or microcavitated occlusal caries lesion. I will show you a clinical case. Here we have a caries lesion. In the radiography, we can see that the lesion is in the outer half of dentin. So we decided to seal the lesion without tissue removal. Here I will share with you the one video with the steps of the procedure. We use phosphoric acid in these cases. And after the phosphoric acid, we use the adhesive system. And then we apply the composite. It's very easy to apply. And we use the flowable one, aiming to get the material inside the fissures and also on the microcavitation. Here we have the, after occlusion, the final aspect. Just let me get my pointer again. And the non-flowable resin is especially very good to use in early childhood, where we have to make very quick procedures, and all you know that. Here we have a 24-month child with Prader-Willi syndrome, in which enamel can present hypomineralization, and after applying acid, wash, dry with cotton balls in these cases because it's in the childhood, we apply the adhesive system and then the injectable resin. Since it is a baby, we could not photograph step by step, but it is quickly and easy to inject the resin in the correct place with the correct shape. Then we light cure. We did not use any device to make the shape, to make the anatomy. Only we inject, allowing, giving the shape. Then we remove the excess manually and with sandpaper. So it's a very easy procedure with this kind of injectable resin. However, when I was studying about Giomer in the literature, I found this clinical report and I got shocked. Look, this is an inactive caries lesion that was removed and restored or replaced with resin composite. And what we have to keep in mind is that bioactivation, bioactivity is interesting and important, but we have to be careful and we have to respect minimal intervention dentistry, because there is no material better than tooth tissues. Why removing tooth tissues without necessity? So caries treatment approach based on active caries preventive treatment and restrictive criteria for restoration placement are good basis for reducing the need for restorations and reducing the chance of restorative death spiral. And the first step of unsuccessful treatment is to focus on patient and not on restoration and not on caries lesion and not on tooth. We have to start to see and to treat patient, not treat tooth. And to treat the patient, we should provide economic, social, and behavioral change. But unfortunately, this is out of our control. Therefore, we have to instruct, we have to guide our patients in order to prevent dysbiosis of the dental plaque, especially by toothbrushing training, sucrose ingestion control, and constant monitoring. And gyomers or S-PRG technology went beyond restorative treatment, because this filler have been also used not to only to restore the lesions, but to prevent the caries lesion and even prevent caries disease. The S-PRG fillers have been used to develop a toothpaste with promising in vitro results on the prevention of remineralization and enhancement of remineralization. However, this is an experimental product. What we have is a coating in the market, is a coating material called S-PRG barrier coat that is indicated to prevent demineralization, enhance remineralization, and diminish hypersensitivity. It is not a varnish, because S-PRG filler, the one that I already explained, fillers, they are diluted in water and mixed with monomers, acidic monomers and initiators. So it's not a varnish, it's a coating material, monomer based, and with S-PRG fillers. Since they have this effect on day and remineralization, they can be used to treat initial caries lesion, as we have been used fluoride varnish. The advantage of this material is regarding the release not only fluoride, but also another ions, as I have already mentioned. Here we have a clinical case of a 3-year-old child presenting caries lesion in the proximal area of the incisors. First, we increased the space between teeth in order to facilitate dental plaque removal by the mother and to place the material. And we applied S-PRG barrier coat, and since it is a coating composed by monomers and S-PRG fillers, after application, we have to light cure. And here we have the final aspect. We have 2 years control of this case, and the lesion is inactive. The other material that is also preventive is the sealant, which also has S-PRG, beauty sealant, so it's called Gyomer. In addition to the S-PRG, it has a self-etching primer that speeds the treatment time by eliminating the need for phosphoric acid etching. Here we have a clinical case. After tooth cleaning, we apply the self-etching primer, we gently dry and then apply the sealant. Both the viscosity and the searing design contribute to a smooth, bubble-free and reduce the common issue of overfilling. Here we see the final aspect, but I don't know if you are looking at me and thinking, oh, how is the adhesion between the sealant and the enamel in this case? Because I did not learn this kind of adhesion or clinical procedure. What we have already seen is, in the conventional sealant, we apply the phosphoric acid onto enamel, and after we wash and dry, we can see a demineralized layer here of enamel with an increased surface area. And this surface area enhances the mechanical interlock between the demineralized enamel and the sealant. So it is a micromechanical adhesion. And again, you are asking me, which is the mechanism of adhesion between enamel and beauty sealant? And this was the question that I made to Mr. Giomer. And then he explained me. Onto the enamel, when you apply the self-etching primer, this primer presents acidic monomers that will expose calcium, okay? And when this calcium is exposed, this monomer binds to the calcium. So there is a chemical adhesion between the monomer of the material and the calcium of the enamel. So this is the mechanism of adhesion. In the literature, there is a manuscript showing a poor retention of this material. And when I saw this paper, I asked Mr. Giomer what did he think about that. And then he explained that an important thing is when you use fluoride toothpaste in the prophylaxis or even toothbrushing immediately before the sealant application, this paste probably will form calcium fluoride, a calcium fluoride layer. And when the primer is applied, this monomer will bind to sodium fluoride and not to the calcium of the tooth. And this adhesion will be with the layer of calcium fluoride and not the calcium of enamel. So there won't be adhesion with enamel. And then this sealant will not be retained in the fissure. However, this direction for use, which is very important, is not present in the direction. Okay, so we have to be careful. And what about molar incisor hypomineralization? Another problem that we face in the clinic is that the higher enamel porosities of these patients allows bacterial invasion and causing chronic pulp inflammation. And this is a huge problem for the family, for the child, and we have to solve. Even when there is no structure loss, no enamel loss, so we can't restore, we can cover, but the patient feels the symptoms. So we have to solve this problem. And in these cases, what we usually use is fluoride varnish, and some cases it is very good, but in some other, it does not solve the problem. The patient is still complaining about pain. So we are testing for these cases of hypersensitivity without tissue loss. We are testing the application of PRG by hair coat because this material has an effect on the sensibility due to the aluminum, that the aluminum reacts with hydroxyl, with phosphorus, with calcium, forming complex that can like close the porosities, relieving the symptoms. So we are conducting this clinical trial. We have to stop the trial due to coronavirus, but we are observing very good and very promising results. But we don't have yet any scientific evidence. I will show the steps of the clinical case here. We can see here the opacities, and the child could not eat on the side or even brush the tooth due to the hypersensitivity. And here the tooth was cleaned. And here another important point, without fluoride paste, because the adhesion of this product is also by chemical bond between the acid monomer of the formulation and the calcium of enamel. It's exactly the same, similar to the beauty sealant. And after drying, we apply a thin layer of S-PRG barrier coat, light cured, and here we have the final aspect, and we have 1.5 year follow-up, and the patient did not have any kind of hypersensitivity anymore in this tooth. So before I finish my presentation, I have to leave you a reflection. Although largely preventable, I'm not saying about hypomineralization, I'm saying about dental caries. Although preventable, dental caries has barely improved in the last 30 years. So we are doing something wrong, like wipe eyes. So I invite you to redirect our view and our procedures. And I think the first step is to see the patient as an individual, as a whole child, and not only tooth or caries lesion. So we are going to be able to treat the disease as a whole, not only the lesion. I think this is the first step. So we have a lot of work to do. Bauru is very hot. I would like to go to the swimming pool, but I have to work and work with all of you. I would like to thank all my colleagues, my students, our staff, the financial support of Brazilian agencies to develop science, Shofu for teaching me about the S-PRG, and a special thank for all of you that is or will be watching this lecture. So, thank you very much, and remember the reflection. We can alter the course of dental caries, but we have to redirect our procedures. Thank you very much. Here are my email and my Instagram. Thank you.
So thank you so much, Dr. Daniela Rios. Thank you for an amazing, amazing, amazing lecture. I am sure that
thank you, Carla.
A lot. So can you hear me okay here now?
Yeah.
Okay, good. So for just few minutes, not more than 5 minutes, I'm gonna read you like some questions that some people just wrote here, and also I'm gonna start for the most likely for you, okay?
Okay.
Maybe if you don't understand some words or some expression or something, we can try to figure out, right?
Okay.
Okay, go ahead. Why is it called bioactive when there is no universal agreement what bioactive is, and there is no ISO standard for dental bioactivity?
This is a very controversial topic because this concept or this definition comes from the medicine, and it's regarding any action of the organism that mimics or simulates the action of the organism. But we use this for the dentistry. It starts on implantology, and they used to say that the material is able to bind to the tissue, the osseous tissue. And also then the Academy of Dental Material uses to say that the the ions leached from the material can stimulate biomineralization, but this biomineralization is regarding dentin. And we don't have this concept on cariology that we can enhance the effect of saliva. So there is no standardization. Who questioned me, it's right, we don't have in dentistry any standardization. We are writing a book and we are having many problems to make a concept or a definition, and that's what we have now. I think in the future some entities like academies can make just agree or not agree with something that can be used and standardized.
Good, good. So let me see the next one. Whoop. Whoa, let me see, wait. Here. Are you saying that geomers, which I believe only Shofu makes, is superior to high pounder liquid glass ionomer? What about the recent study in adhesive dentistry that there is no statistical difference between ECA and tetric ceram?
Oh, I did not mean that. What we have, as I said in my presentation, I am a glass ionomer lover because it's a very good material. I think that is a permanent material, as we have been seeing some studies. This year, we have a study with 10-year follow-up in permanent teeth. So it's a very good material. And we don't have clinical trials with higher follow-ups. We have only one with, I think, 2 or 1 year. So I can't say that because I don't have any evidence. What we have evidence regarding geomer is in situ and in vitro studies and some clinical trials with small follow-up. Maybe in the future I can say that, but until now I cannot. And I really like glass ionomer cement. I think that is a great material.
Good. Due to hypersensitive nature of this lesion, I think that is maybe about the MID, is it better to use ubstezine as a local anesthesia? Like the articaine?
Ah, okay.
Yeah, he's asking about if it's better to use articaine for us in Brazil when you have, because of the hypersensitive of MID.
Okay.
Use or not?
I use not to use the articaine because the safety of this anesthetic, it's not like lidocaine or mepivacaine. So I prefer to use those ones. And I think that the effect is similar because the tissue has inflammation, and even articaine we cannot get the result that we want. So I think it's not necessary and will not work. That's my experience.
Good. For how long is fluoride dentifrice not recommended before and after treatment with geomers?
We really cannot answer this question. What we know is that when you use immediately before, there is a formation of calcium fluoride. When we use fluoride dentistry, this is the mechanism of action of the fluoride dentistry. It develops the calcium fluoride. But this calcium fluoride, with time, it gets lost. And we really don't know if this loss, how it will compromise, the extent of compromise regarding the adhesion of the material. So until now, we just say that immediately before we should not use, because we cannot control our patient. He will brush his teeth in the house before he comes to the clinic. So this we cannot control, but we can control our procedure, not making or not using fluoride before the procedure.
Okay. Why it takes 1 year to recovery?
I didn't.
Yeah, maybe why should I have to recovery 1 year after the procedure or something like that?
I think it's the follow-up.
Yeah, probably.
I really did not understand, but I will try to answer. I don't know if it's the follow-up of the PRG barrier coat or the follow-up of the restoration. Regarding restoration, I will first explain. The patients with hypomineralization, the procedures that we do is not, how can I say, definitive forever, and it's probably it will fail, so we have to call this patient frequently. So we used to see them 3 months, then again 3 months, to see if our procedure is still there. So we have this kind of follow-up. And regarding the PRG barrier coat, there is the industry, they advise to reapply 3 months after the first application, but we are not doing this because we are reapplying when the patient says that the sensitivity is again there. So this is the reason for this patient that even after 1 year and a half, we did not apply again. I don't know regarding the prevention of caries. This we are going also to study, but regarding the outcome sensitivity, we are waiting the patient complying.
Okay. How do you compare Beautiful 2 with the regular composite? And they have the same properties related with longevity of the restoration?
We don't have clinical trials. The only clinical trial in primary teeth is the one that I present in my lecture with 1 year follow-up. The in vitro studies shows very similar mechanical properties. So in vitro and in situ, they are similar, but we have to have more clinical evidence. That is the highest level of evidence. And as I said, we are building the evidence. We don't have answer for every question that we have to do until now, but we are building this evidence. And I'm saying we researchers of all around the world.
Good. So the last one, because our time is done, the quote that you gave to MID case, it can prevent caries too?
Yes, the in vitro studies shows that that this material has a very good effect because there is S-PRG filler, and the S-PRG filler presents all those mechanisms of prevention. So the evidence of in vitro studies shows that it can prevent, but we have also to see the clinical results. And we don't have it yet. We are testing this in the hypomineralization. If it's able to solve the hypersensitivity, and also if this material can enhance the prevention of caries lesion. Maybe next time I can answer this question.
Good, like the next conference, 1 more year.
Yeah, I hope so, but I hope it won't be virtual.
That's true. So our time is done. Unfortunately, we can talk a lot here, but thank you so much, Dr. Daniela. It was amazing, the lecture one more time. So thank you so much for everyone to be here, enjoying with us all the lecture. And have a great Congress. We still have some days about it. And thank you again, Dr. Daniela. Thank you so much.
Thank you, Carla, for all these very kind questions, and for all you that are watching us. And I really wish to be everybody safe.
Good. Thank you. Thank you. Bye-bye. Bye-bye, everyone.
Bye.